Hi there, I am Chris Martinson. Today is the 2nd of January 2021. I am in the biochemistry course doing case connections number 4. So with this case connection, I decided to look at both case number 1 and case number 3. So starting with case number 1, we have this newborn girl who presents, or who's born, and then 24 hours later presents with lethargy or kind of a lack of energy or activity, hypothermia or low body temperature, and then apnea or temporary cessations in breathing. And the doctor believes that this is from a metabolic disorder. He is unsure of whether it is a beta oxidation deficiency or a deficiency in the urea cycle. So the physician wants to take a look at several different blood tests to determine which test is the best at differentiating these and determining which pathway this is from. So looking through the 4 options, 2 of them, I should read them off for you. The options are blood glucose, urinary acids, serum fatty acids, and plasma glutamine. So 2 of these we can get rid of fairly quickly. The first one is blood glucose. Now, with beta oxidation deficiency, it is possible to see a decreased level of blood glucose. This decreased level is not part of the diagnostic features of it, and you won't typically see it with the urea cycle deficiency. So this one isn't a very conclusive test for determining which pathway it is. The next pathway that we look at and can dismiss pretty easy is the plasma glutamine. With plasma glutamine, it's likely that this would be elevated in a urea cycle disorder, but you really don't see too much changing with it with beta oxidation. Some sources say that there might be a slight lowering, but this isn't a test that is used to diagnose either one of these conditions. So that is why I eliminated it as a good test to use. The final 2, I think you could really use either of these to determine which pathway it's from. So the first one I will talk about are serum fatty acids. We would see these levels elevated with beta oxidation, and this would be a good test, like I said earlier, for determining the metabolic pathway. However, it is not too specific with different disorders within beta oxidation. Now, if you go into the urinary acids test, this would be a great example for finding the deficiencies in the urea cycle. While you can have elevated urinary acids with beta oxidation, they tend to be different types of acids. Mainly, beta oxidations are usually seen as glutaric, ethylmalonic, and dicarboxylic acids in the plasma. With the urinary acids, we can see an increase in uric and amino acids, and these would be the defining traits of a urea cycle deficiency. And depending on the type of acids found in the urinary, you can get a little more specific with the type of urea cycle deficiency. So we get results on this newborn girl, and the results show an elevated level of blood ammonia or hyperammonuria, and then that continued to rise even later, as well as a urine uric acid, which was markedly elevated from 0 to 3 all the way up to 473 micromoles per liter of creatinine. And then plasma citrulline level is slightly low, maybe normal. So looking at all of these, the big ones that we want to note are the elevated ammonia and the elevated uric acid. This tells us that the deficiency is definitely within the urea cycle. And with the elevated orotic acid levels, this is most likely a deficiency of ornithine transcarbamylase, or OTC, and least likely to be carbamoyl phosphate synthetase 1, or CPS1. We see a significant or a slightly lower plasma citrulline level, which can be indicative because of an OTC deficiency. And CPS1 is the least likely option because orotic acids increase as a result of the accumulation of carbamoyl phosphate. So with these, I would expect the deficiency to be with OTC. Moving on to case number 3, we have a 47-year-old male who presents with gout, pretty much. He notes pain in his great right toe. It's more painful to pressure, and there were no signs of trauma. So, looking at this and seeing it as gout, we also see he has elevated plasma urate levels and decreased urinary uric acid. So, we want to determine the source or the root cause of gout in this patient. Looking at these numbers and the 3 options that could really be the cause of gout, there's one that kind of stands out to me a little more than the others. The 3 options are an overproduction of purines, a decreased salvage of purines, or a decreased urinary excretion of uric acid. I think the easiest one to get rid of is the decreased salvage of purines. We can throw this out due to the decreased level of urinary uric acid, because we can see that with Lesch-Nyhan syndrome, that you would expect to see an increase in the urinary uric acid levels instead of a decrease. So likely not that one. Now we're down to the overproduction of purines and the decreased urinary excretion of uric acid. Looking at the overproduction of purines, this one is possible, especially with the elevated plasma urate levels. However, I think that you would also see a pretty similar or even slightly elevated level of urinary uric acid with this as well. Going into the last cause, the decreased urinary excretion of uric acid, by definition, that's pretty much what we see in that second test, the urinary uric acid test. We see that the levels are almost cut in half. The patient's at low 200s instead of 400 to 500s for the normal patient. You can also take a few more tests to look into this to maybe make it more secure. If you check for other urinary acids, as well as like blood lactate levels, these could help you distinguish between those two even more. If you saw other urine or other acids in the urine, that would be a sign that the gout is primarily caused due to a lack of ability to excrete these uric acids. However, if you see elevated lactate levels in the blood, this could be a problem with glycogen storage, potentially a von Gerke's disease, which could then increase the production of purines. So, while those two are the options, I'd lean more towards seeing this as a source of that urinary excretion of uric acid. However, after talking to the patient a little more, we find out that he notes that he has been consuming 4 to 5 liters of regular pop or soda every day because he heard that the fake sugars in diet soda are bad for him. So with this increase in fructose, this tends to lean me to believe that the presentation is due to a overproduction of purines again. This is because there is a direct correlation with fructose and production of purines. And this is seen in several studies. Also, for all of my work in this assignment, I have listed my references on my my template or script. So thank you and have a great day. Bye.